Thank you so much for this kind introduction, and of course the organizers. I'd like to thank them for inviting me, for allowing me to talk today. And my respect to you all, because you could have gone outside or go home or enjoy the weather, and you decided to stay. Thank you for that. I hope not to disappoint you. We're going to talk about, I guess, some interesting stuff about decision-making, and we'll focus a bit on decision-making in the gray zone, because that is the area where we all struggle most, I would say, I would expect. So let's start off with some good news. Children who are admitted to the intensive care unit are all critically ill, and most survive. Mechanical ventilation and other medical technology keeps them alive, and most recover, which is good news. And the overall mortality rate in IC units has decreased in most industrialized countries, and there are many reasons for that. At the same time, we have to acknowledge that still around 5 children per 100,000 live births die, and about 50% of pediatric deaths occur prior to the first year of life. So it seems logical to focus on those first years. Although more children who previously died in the hospital are now dying at home, the majority of pediatric deaths still occurs in hospitals, mostly on the intensive care units, where many of you probably work. This is a slide that shows you the causes of death of the pediatric population in the Netherlands in 2017. The total number of deaths each year, and also in 2017, is around 1,100. On the horizontal axis, you see the ICD-10 diagnostic categories as causes of deaths, and on the vertical axis, you see the number of deaths. The colored lines are age groups, and the dark blue color represents children dying between 0 and 12 months of age. Then red is 1 to 5, green is 5 to 10, purple is 10 to 15, and 15 to 20 is light blue. And as you can see, the biggest peak is perinatal disease, congenital malformation, and it's the biggest peak in the pediatric population. So the other peak in 15 to 20 years is suicide and car accidents. And the other colors, as you can see, represent only a few deaths in very many different specialties. So it makes sense to, if you want to know how children die, to focus on children between 0 and 12 months. And this is actually what has happened in the last 10 to 15 years. A lot of new knowledge came from outcome studies, from analysis, to find out how children die and what roles are taken by doctors and parents. So today, in many units, the main mode of death is withholding or withdrawing life-sustaining treatments. These decisions are usually made by healthcare teams together with parents, and they intend to prevent suffering, to promote comfort, quality of life, and dignity. This seems the right thing to do, and in line with the presumption, the general presumption in bioethics, that decisions should always be taken in the child's best interest. So, in the course of time, we come to realize that the child's best interest is probably a touchstone to determine whether or not life-sustaining treatment may be withheld or withdrawn. Now, how does that work out in practice? Here are some important questions about practice, the practice of withholding or withdrawing life-sustaining treatments, that are relevant to find out how does the decision-making actually go about. How are they made, the decisions? What are the reasons used? What are the arguments that are used to make those decisions to withhold or withdraw? What is the division of roles? between parents and doctors. What about conflicts? Conflict resolution. Conflicts may be a sign that parents and doctors, or maybe doctors and doctors, do not agree on what is in the best interest of the child. What are conflicts about? How are they resolved? So if you look at outcome studies in the last 10 to 15 years, and I've put down a few on these slides, you see that generally the proportion of deaths in large studies after withholding or withdrawing life support is high. As high as 70, 80, even 90% of deaths in some units after a decision to withhold or withdraw life support. There are some exceptions. For instance, Korea, a recent study showing only 27% of deaths after withholding or withdrawing. But over time, you see that the number is increasing, and that it's in most Western countries, it's the same. So this is what is clear from those studies. Most neonatal deaths in the NICU occur after life-sustaining treatments are withdrawn or withheld. Babies don't just die. What we do not know from those studies is, were those neonates actually dying when treatment was withheld or withdrawn? Or were they physiologically stable babies, electively taken off the ventilator for quality of life reasons? You wouldn't read that from those studies, from most of those studies. Did the babies really die after withholding or withdrawing took place? Or was medication given to hasten death? So this is to show you a study that we did several years ago to find out the details of how newborns die in our country. And we looked at all 10 units in the country and looked at the number of babies that died during 1 year and analyzed those files and talked to all the doctors that were involved in the dying process and in the decision-making process. And we found that in that year, around 360 babies died, and 82% died after withdrawing of artificial ventilation. In 13% artificial ventilation, life support was withheld, and 5% died during CPR. Then we went on dividing those deaths between first the blue part of this circle, the unstable babies who were actually busy dying. We took out the tube, we stopped the ventilator, gave the child to the mom or dad to die. And we separated them from the red part, the babies who were physiologically stable. They could have lived on for hours, for weeks, or maybe for months. But still it was decided that the artificial ventilation should be stopped, taken out the tube. We gave the child was given to the parents as well and died. So 58% was busy dying. We took them off the ventilator to make it a more pleasant death. And 42% died that could have lived on. If we look at those 10 units, we see that the proportion of red and blue, the stable and unstable babies where decisions were made, are more or less similar. Around, let's say, 40-60 or 45-55% blue and red. Now, what were the quality of life considerations that were used by those doctors that decided to stop the ventilation in stable babies? Part of them related to the actual situation, the upper part. But as you can see, the predicted suffering was the most used argument by the doctors. So it wasn't so bad at the time that when the ventilator was taken off. It was the predicted pain, the predicted dyspnea, the predicted physical suffering that made them decide to stop the ventilator. So we were surprised when we found this. We didn't know that it was so much quality of life decision making. And we decided to make an international comparison to find out, are we weird and the others normal, or how does that work? And we did a study together with 2 units in the US, one in Chicago. Bill Meadow was our co-investigator there. Steve Leutner in Milwaukee, and Annie Janvier in Montreal, Canada. We did a similar study dividing deaths in a fixed manner and dividing all deaths between stable and unstable groups. And here you see the results. The blue bars representing again the unstable babies that were busy dying. We took them off the ventilator to have them die on the chest of the mom. And the red bars representing withdrawal of ventilation because of quality of life consideration. And interestingly, where we thought that we were the strange clinic in Groningen, we actually found a similar practice in both Montreal and Milwaukee, and the biggest difference was between Chicago and Milwaukee. And those units are like 1.5 hours drive separated, so very close. And we asked the doctors in Chicago, how can it be so different in your unit? Why do you never take decisions based on quality of life? And Bill Meadow, who sadly died last week, by the way, explained it this way. He said, our unit is located in a very poor, very Catholic, very black community. The people find themselves discriminated against for their entire lives. If those moms come in, they would typically say, I want you to do everything you can. Don't start discriminating my child even before it's born. So, and the doctors accept that. They do everything they can. So they do not make many decisions based on no decisions based on quality of life, and they often have death on the ventilator or during CPR. At the end, of course, a lot of babies die in that unit as well, but parents at least are happy, relatively happy, because they could say, I've seen that you've done everything you could. And the doctors too feel good, because they would say, you asked me to do everything I could. I really did everything I had. I did everything I could, and so also the doctors feel good. If you would come to Groningen, and probably also Montreal and Milwaukee, parents would never ask, or hardly ever ask us to do everything we can. They would typically say, if my child gets into trouble, and you think that the future might be problematic with a lot of disabilities, I'm not going to ask you to continue treatment. If you feel that it's better to stop treatment, we're okay. So that is a totally different approach from parents towards the same medical problems as the parents in Chicago have. So it wasn't until we gathered the data that we could illustrate that. So the decision-making process about stable infants with a very poor prognosis in our study was mainly initiated by doctors, and parents were always involved. So they were always involved in the decision-making process. Conflicts occurred. Conflicts between members of the team in 4% and between the medical team and the parents in 13%. And those conflicts were about what is the best way to treat this child. Conflict resolution worked in 2 ways. So sometimes the parents asked us to continue life support where we thought, or the doctors thought, it would be better to stop. And sometimes they asked us to discontinue where we thought continue treatment would be better. But they were all resolved, those conflicts, by giving time, by taking time, postponing decisions, having more discussions, and adding more diagnostic tools and diagnostics and second opinions. So if we take a sidestep to the PICU, there is a lot of newborns in PICUs in the world as well. We see that most end-of-life decisions in the pediatric intensive care unit are in children with complex chronic condition. Many of them were in the NICU before. The main mode of death, also in that place, is withholding or withdrawing life support. These children and families come to the PICU with a vast accumulated knowledge and experience about medical technologies and health bureaucracies. They're different parents. They know that the technology can be wonderful and technology can be horrible. Parents are empowered because of all that. They've learned a lot, but they're also vulnerable because of all that they've experienced. And it's not surprising that not all parents want to be involved in decision-making in the same way. This makes decision-making even more problematic and difficult. In some countries, it's important to realize that parents must not only accept the loss of hope, but they must also explicitly endorse a plan in which life-sustaining treatments are withheld or withdrawn. This is not the case in the Netherlands. A different approach is preferred there, and in other countries as well. Parents are not asked to make the decision. Instead, the decision falls to the doctor. So, if we want to know how decision-making is done in the PICU, at least in our country, we have to look at the interesting study that was published by Mirjam de Vos in Pediatrics in 2011. She did a national cross-sectional survey among 136 pediatricians involved in end-of-life care and withdrawal of ventilation in stable patients. She found that physicians differ considerably in how they involve parents in the process. Around 50% inform parents and ask for permission. 25% would inform and decide to protect the parents. That's their argument. 25% would advise parents and let them decide. There were also conflicts in the PICU. Conflicts between the medical team, 13%, and between parents and the medical team about what is best for the patient in 20% of cases, which is a lot. These conflicts, too, were ultimately all resolved by taking more time, intensify the discussion, and by ordering more diagnostics and second and third opinions. So there are a lot of challenges in decision-making. From the literature that I've just cited, we know that in the NICU and the PICU, death seldom just happens. Decisions to limit life-saving treatments in stable patients are difficult for all involved, and conflicts about what is best for the child between doctors and parents are not uncommon. Physicians differ in how they involve parents, and not all parents want to be involved in the same manner. How can we facilitate and improve end-of-life decision-making? So there is a model that ethicists use to balance the child's interest and the scope of parental authority. And it's a model that is based on the view that physicians are responsible to decide whether a treatment is either beneficial or futile or somewhere in between. And in that model, the green zone is the zone where treatment is clearly beneficial for the child. The child's right to treatment outweighs the parent's right to make medical decisions for their babies. So even if the parents don't agree, you would still impose or start a certain treatment. That is the green zone. It's the easy zone. Then we look at the red zone. In that model, the red zone is where treatment is clearly futile. It causes harm. It's not in the child's interest. It should not be provided despite parental preferences. And there is, of course, the gray zone. The model acknowledges that there is inevitably a gray zone in medicine today. In that gray zone, treatment benefits are less clear. Many options are legal. Reasonable people disagree about the right thing to do, and a decision must be made. This is the area where parents and doctors struggle to find out how they get out of the difficult situation. All the options that they have are legally permissible and ethically defensible. And still you have to choose. If it is ambiguous whether a decision is in the child's interest, ethicists and courts defer to parental choices. So it is within the gray area that we choose for parental choices. let's focus a bit on decision-making in the gray zone. Because over time, we've seen that there has developed a shift of focus from the result of decision-making process to the process itself. A shift from the doctor as information provider to shared decision-making as an approach. Until recently, doctors saw their primary role as providing parents with detailed, objective information about treatment choices and likely outcomes. The facts. We presented the facts to the parents. That was what we until recently did. It is very difficult to transfer information to parents. We know that from the increasing amount of literature on this issue. Facts are not always known and straightforward. And how facts are presented affects the choice parents make. If we put the worst possible outcome at the beginning of the list as compared to at the end of the list, we are affecting parental choices. Decision-making is multifaceted, and understanding risk information depends on many factors such as experience, trust, tolerance to risk, and/or uncertainty. In addition, our care teams are constantly rotating, and healthcare providers have different views and attitudes which influence how they talk to parents. So, a newer approach recommends that doctors involve parents in decision-making by helping them discern their own values and ethical commitments, to acknowledge that there is no simple way to present the fact. So why are we shifting towards shared decision-making? Well, first of all, because the old way didn't work well. Parents of critically ill children do not make decisions by calculating the likelihood of specific outcomes. Instead, they try to figure out what it means to be a good parent for their critically ill child. Parents take decisions partly by the head, partly with the heart, probably just like you. Most of the important decisions that people like you and me make are not purely rational. I think that not many of you have chosen your partner based on the genetic profile. If you buy a house, it may not be the best house in the area, but it's the house that you like. If you buy a car, you buy the car that you like, and not the car that is scientifically the best of all. So probably we do the same as what parents do. It's not just rational, it's also the heart that decides. Facts do not speak for themselves. They are always communicated in ways that shape how people interpret them. And that shapes the decision that follows. So the doctor's role should be to help parents understand not just the clinical situation and the prognosis, but to help them understand the meaning of the choices in the light of that clinical situation, which is different. Doctors should help parents articulate their hopes and fears and value commitments, and then connect to those in the decision at hand. Then how can doctors help parents? They can help parents by being aware of their own beliefs and unconscious biases. They should learn to ask parents open-ended questions about hopes and fears, goals and values, and then listen carefully for elements in that answer and connect to them for the decision. And maybe the most important thing, accept parental gray zone decisions that may be different from what doctors and nurses prefer. That is the gray zone. So what about the boundaries between those zones? Where does gray end and red start? Where does gray end and green start? Is that similar in all our hospitals? No. It is determined by a mix of legal, political, economic, and cultural factors. And in addition, boundaries are shifting. Think about surgery for children with trisomy 21. Used to be red zone, then moved up to gray and is now green. What about treatment for children with trisomy 13 and 18? Used to be red in my country, and it's gradually becoming gray. Parental discretion in periviable babies is another example. And that's an example that I would like to zoom into. Because we did a study recently, together with Dom Wilkinson in Oxford and Stephen Johansson in Stockholm, and we compared resuscitation threshold in extremely premature infants between neonatologists in the UK, Sweden, and the Netherlands. And we wanted to find out, in all those three countries, when is a baby too immature to resuscitate for them? What is the lower threshold? Where does red start and gray end when it concerns extremely premature babies, the resuscitation? Oh. And at the same time, we wanted to know, when is a baby sufficiently mature to consider active resuscitation mandatory? What is the upper threshold? Where does the green zone begin? Even if the parents want non-resuscitation, you would still do it. And this is what we found. On the x-axis, you see the gestational age, and on the y-axis, it's the proportion of respondents that chooses. And the yellow bar is Netherlands, blue is Sweden, UK is red. So this is the separation between the red zone and the gray zone, the lower threshold. And for the Dutch, the lower threshold, no resuscitation, even if the parents would ask us, would be around 24 weeks. In the UK, it would be 23. And in Sweden, most neonatologists would say, below 22 weeks, I would not consider a resuscitation, even when the parents would ask me. So the red zone and the gray zone is very different at this subject in those three countries. What about the border of the green zone? When would you not resuscitate a child if the parents requested you not to do it? Interestingly, the Dutch neonatologist said, until 26 or 27 weeks, we would not resuscitate if the parents wouldn't want us to do so. Very different from the UK neonatologist, who would say, for us, the line is at 24. Above 24, we would do it, even if the parents don't want it. And the Swedish neonatologists have their line at 23 weeks. So a huge difference in where the red and green zone are in those countries. This was gestational age as cutoff point. We also looked at prognosis as deciding element. And there, the differences were less great or smaller, considerably smaller. Look at this slide. On the lower axis, you see the probability of survival without profound disability. And on the y-axis, it's the proportion of respondents. And let's follow the yellow line of the Dutch. It starts at a 0 survival chance without profound disabilities. No neonatologist would provide resuscitation. And then gradually it increases. And at 10% chance of survival without profound disability, half of them would provide resuscitation. Whereas 100%, that is the broken line yellow above, 100% would not resuscitate if the parents would ask them not to resuscitate. So if you look at it this way, you see that those fixed lines and those broken lines aren't too much separated from each other. So maybe prognosis-based decisions would be a bit better than the gestational age decisions. Anyway, if we summarize decision-making in the gray zone and in neonatology, it's fair to say that most deaths are by withholding or withdrawing, also in stable patients where treatment could have been continued. The decision-making process is complex, and conflicts between teams and parents about what is best for the patients are not uncommon. There's an ethical framework to balance the child's interests with the scope of parental authority. It divides three zones: the gray zone, the red zone, and the green zone. If we focus on the gray zone, where reasonable people disagree about the right thing to do, we defer to parental choices. Of note, gray zone boundaries vary between units and countries, and they shift. In the gray zone, the doctor's role shifted from information provider towards, nowadays, helper in a shared decision-making approach, empowering patients, accepting their choices. Doctors who have these difficult conversations with parents require skills that can be taught and can be learned. These skills will ultimately improve quality of care in the NICU and PICU. I am convinced of that. Thank you for your attention.